Right, thank you all for coming today, and it's great to see we had about 92 people sign up, and great to see people just coming and such enthusiasm really for an area certainly that's very, very close to my heart. Just before we start, just a couple of things. I've got problems with my internet today, is probably the rain. So I then turn the video off because it just keeps I'm the clinical lead for LD working across NEL. And today I have my fantastic team with me who I'm going to ask to introduce themselves now. So Binny.
Hello everyone, I'm Binny Thomas. I'm a consultant at Trust in Havering, Northeast London Foundation Trust, and the AMD for LD services.
Thank you, Binny. Masuma? Masuma, mute. That seems to be the dialogue of the year, isn't it?
Hi, everyone. I'm Masuma Chowdhury. I'm the Learning Disabilities and Autism Project Manager for Northeast London. Thank you all for joining.
Thank you, Masuma. Is Rachel here? Rachel Penny? Not yet. Okay. Can I also thank the BHR Training Hub for hosting this event? And Chi and Bola, if you could just do a quick introduction as well.
Hello, everyone. I'm Chi. I'm the BHR Project Delivery Officer. Welcome, everybody.
Hi, everyone.
Bola, carry on.
Hi, everyone. My name is Bola Demewa, and I'm the Education and Development Officer, and I'll be taking the lead on the Learning and Disability Forum for the BHR CEPN.
Thank you, Bola. So just a bit of housekeeping things. If everybody could turn their videos off and mute themselves for now. I think there are lots of people that are having problems with the internet today. It's just, I think it's a narrow band. And that's what I have just turned off my video. So apologies that you can't see me, but hopefully you can hear really well. What the plan is, we're going to deliver some sort of a basic understanding of the QI project in relation to the LD today. We have a short quiz after that and then questions. However, I never keep to time in any of my presentations. So if you wouldn't mind putting the questions onto the chat, my team here will answer as we go along. Obviously, if there are questions that need to be asked at the end, the team will put that forward to the to us. But equally, we may have to take some questions away and get back to you. So thank you for that. We are today presenting on behalf of the LD team. And as you're aware, LD QoF is part of the primary care work stream. However, primary care are in agreement with the contents of the webinar, so hopefully there won't be any questions in terms of what we're delivering today. So next slide, please. So as always with anything, we look at what we're trying to achieve today. So it's really two main things, is understanding the QoF requirements and the COVID adaptation. But equally, I'm hoping that we can start generating some thinking and ideas for you to develop your own QI plans locally. What we are not doing today is teaching people how to do QI or going through the QI methodology. I think your primary care team should be able to help you with QI training. A lot of people, certainly in my patch BHR, have had training already. There is support out there for people who actually want to learn how to do the QI. Thank you. Next slide, please, Bola. So I'm going to start off with a definition. So when preparing for this webinar, I searched for the definition, and not surprisingly, there were very many definitions that I found, but I chose this one because I think it describes QI well as an interplay between the approach, the environment, as well as describes the steps in QI that are the key really difference between the QI and audit, which are designing, testing and implementing the change for a real-time improvement. For those people that are interested in this BMG article reference, actually really good discussion on QI, how to do a QI and the benefits of doing the QI. I often get asked, certainly from my trainees, what the difference between an audit and a QI is. And actually for me, simple person, simple thinking, is that an audit is looking at everyday clinical care, comparing against some set standards. And QI, you can think of doing smaller audits using certain methodology to make some recommendation that you then follow through. So you're doing cycles of audits to try and achieve the right outcome and a sustainable outcome. Next slide, please, Chi. Now, one of the reasons is, why are we doing this? Well, actually, it's been forced on us. We have to do it. It's the QI methodology for both cancer and LD that we have to use, showing continual improvement on care. So we just have to deliver it. The other bit, of course, is for those that are GP trainers here, that is now part of the work-based assessment for the GP trainees. And it's hoped that all the new GPs that are going to come out will have a fairly good idea on how to run these projects. I would encourage the training practices to involve trainees, particularly in LD, especially just really close to my heart, that subject. But of course, cancer is the other area. I have attached some links here. The first link is actually the QI, sort of details of the QI plan and what you expect it to do. The second link is for the Royal College Improvement Guide. I think it's a fantastic guide, written for the GPs, very simple language, and goes through step by step exactly what you need to do in your practice. So those people that can't get training locally, if you go to that guide, I think certainly you would be able to do a QI in your patches just reading that guidance. Thank you, Chi. Next slide, please. So as you're aware, the NHS long-term plan, one of the aims is to improve timely and appropriate health checks, but also to improve the level of awareness and understanding for all the staff supporting the patients. And the aims have really arisen from the evidence that we've had. And I'm going to just run through three main bits of evidence, but there is loads out there in terms of which highlights the inequity and gaps in care. Now, looking at the later report, which has just recently been published, this is looking at the mortality in patients with learning disability. Shockingly, median age of death 40 years. Causes of death, which the report said were actually preventable and not necessarily in the order, is pneumonias, aspiration, sepsis, CVD, and epilepsy. We also note from the public health report that patients with LD are twice likely to have comorbidities like mental health issues, obesity, constipation, GORD. And the importance of that is actually, that if you're aware of that, you would ask for those when you do your annual health check. The CPOL, again, is looking at the mortality and deaths in patients with learning disability, and again showing that 42% of the deaths are premature. And actually, more worryingly, deaths are as a result of delayed diagnosis, delay in treatment, and accessing care when the needs change. And again, I've actually put in some references here for practices to go and have further reading if they would like. I particularly would ask practice if they could read the letter report. It's quite powerful, certainly brought a tear to my eye, makes really powerful reading and really highlights those gaps. Thank you, Jay. Next slide, please. Okay, this talks now about the QOF requirements, and quite simply, as one would imagine, is using a QI approach in demonstrating continual improvement, having as a minimum 2 peer review meetings. It sounds really, really simple, and actually it is. Now, you probably have heard that the recent guidance from NHS England is stressing the need to continue our efforts and focus on increasing the annual health check. So this part of the QOF is not suspended. In fact, it's been identified as an area that we absolutely need to renew our attention to and on. Thank you. Next slide, please, Jane. Okay, now I'm going to talk a bit about the modules within the framework that's been given to us for QI. And you can think of these as aims. What are we trying to achieve? And there are 5 main areas that we are focusing on. The first bit is focusing on the prevalence. And to remind everyone, we are targeting 75%, even higher, I would say even 100 if you can. However, with COVID, there was a guidance suggesting that it can be dropped down to 67, I don't want to emphasize too much on it because I just feel that if you can do as many, please do. But just to confirm that pre-COVID, the target was 75, it has been reduced to 67. Annual health check is another area. Now, at the moment, we are across NEL showing quite low figures, but I understand most of the practices do the work in the last quarter, and certainly in terms of LD, and I'm still hoping that would go up. Attached to that is the action plan. Now, for people that have done some of the work, you would know that within the template, the action plan is not embedded. So you almost have to finish the template on your records and then come out and search for the action plan. Then that has populated data for then that to be passed on to the patient, which is something that I have fed up to the national team because I think it was a link. It's just two-step and it's just too clunky that. But as of now, we've got that in two-step stage. The other bit is looking at medication. So STOP project. So this is this means really what it stands for is stopping over medication in people with learning disabilities with psychotropic medication. Now, there was a trend that people with behavior issue, learning disabled patients with behavior seen as challenging, were put on these drugs. So it's about reviewing those drugs, about understanding whether they are actually needed for those patients. And more importantly, if they are needed, have we checked about the side effects, certainly in terms of the metabolic symptoms? Do they need screening for diabetes, lipids, etc.? In most of the areas, certainly in my patch, the local medicines management and pharmacy teams are supporting this. Can I just check with Rachel and Binny, is that the case in every area? Rachel, Binny, do you know?
Certainly for BHR.
Okay, so the local medicines management and pharmacist team are helping. I don't know about the other patches, but we can certainly get back to you in terms of that question that I posed to myself. Now, the other bit of the aim is recording reasonable adjustments. And this requires a focus on how patients, for example, communicates. If they've got a hearing, visual, reading problem, this could mean accessing appointments or accessing care, and that's tailored for their need. It could be, for example, recording, if the patient's got any swallowing issues and they require liquid medication. You could, ask the local LD teams if you are not sure about what reasonable adjustments to make. I would just bring in Binny here to just, Binny, can you give me some other examples of reasonable adjustments to be made during annual health checks or when you're reviewing your patient?
So I think thanks, Jyoti, I think it starts from identifying the patient. Well, as you said, the easier bits about whether they have any hearing impairment or visual impairment, easy read invitation letters, making sure that people who are important to them and who would make it a much more easy experience for them, for example, their carers, or if it's someone from LD team, they're more comfortable with making sure that they are invited for the annual health check as well. And and providing them with easy read information about what to expect. So the step one of what could be done at home, writing what their queries are, and making sure they're ready when they come and see you for the annual health check.
Thanks, Binny. And just to mention, Binny, I think we and I had a discussion about patients who can't have flu injections. Mm-hmm. One of the reasonable adjustments would be having nasal flues.
Absolutely.
That would be acceptable. But equally, for patients that are scared of needles, the local LD team can do some work around desensitization. And again, that will be a form of reasonable adjustment to receiving that flu jab. I also think actually annual health check in a way is a reasonable adjustment because these patients can't proactively come to you. So you're really having to proactively develop something so they can access and we can screen them, treat them in a timely fashion, really. The last bit in terms of the aims is engaging with the wider LD teams. Now, we did hear loud and clear at the last webinar we ran about the lack of, lack of connection with the local LD teams in certain areas. Now, we are going to be working with the LD teams in each area to try and build those links. But equally, after this webinar, when we share the slides, I've got a link or leaflets attached with all patches, local LD teams, which I would urge that you make contact with. It's also about your social prescriber. So for example, social prescriber signing for signposting for carers assessment or signposting to the local offer. And I know there is work being done also within the social prescribing teams to try and get some LD training for exactly these sort of roles. Next slide, please. I'm going to talk about the steps that are that the guidance is suggesting. Now, it's quite helpfully defined 5 steps needed to be taken by the practice. The first step is for the practice team to look at evaluating the quality of care that's provided. So it's that baseline data. How many health checks have we done? How many patients have had reasonable adjustment recorded? How many patients do we know their ethnicity? How many patients have had flu jabs? So that's your baseline data. Once you've identified those gaps from the baseline data, you create a plan. The plan should be based on those gaps. You then implement the plan and then have, as a minimum, as we discussed before, 2 peer review meetings, and finally complete the monitoring template. And that's your QI done. Sounds really simple. And actually, when I read the guidance, I thought actually it is simple. So just moving on to the next slide, please. I don't think it's too onerous, really, just looking at this. Now, I just wanted to share this QI monitoring template with you. So this is what you would require to fill out, answer, and submit for getting the tick box and getting the payments through. And not surprisingly, again, the first question is around prevalence and recording ethnicity. I think the second bit about the BAME thing came through from COVID and the increased risk of the BAME population being at the risk of COVID, really. So it's about accurately recording and increasing your prevalence and recording the ethnicity. The second bit is about annual health check. Now, as I've said before, I think it was in September or October, we got a letter to say, actually, we need to renew our focus on ensuring that the annual health checks are restored. So you could answer in here, what steps the practice has taken, which could be using the blended approach, using the online consultation approach, using the certain sort of invites for patient, getting the data before the patient comes in for the relevant examination and blood tests. The second bit is, or the third question is about the flu jab. This is looking at really comparing your 1920 to 2021 data. And here you may wish to add what steps the practice has taken to achieve, to narrow the gap, essentially. Equally, you may not have a gap, you might be doing really well, but it's really about understanding about, have you made any reasonable adjustments? How have you done with the flu vaccines, essentially? Now, the DNA CPR, which is the next question, you might remember reports floating around, including in the media, which absolutely failed the Daily Mail test, was that some elderly and LD patients were having DNA CPR added to their records without any further discussion with the family or even with the patient. And it wasn't probably in the best interest, or it was, but it certainly wasn't documented. So this is about you sort of looking at the records and seeing if it's still appropriate for them to have that status on their records. I'm going to move on to the next one, that is now this next question is about what you've done. So this is the real crux of the quality improvement, that you will talk about the processes and the changes in practice. And this could be that you've had, for example, LD training for all your staff in your practice. In relation to annual health check, you could say that you're now offering longer appointments. You're looking at DNA, you're looking at home visit approaches. You can also look at doing this sort of blended or hybrid approach to the consultations in an annual health check. You could talk about steps you've taken to increase the prevalence and how that will be sustained. Example, recoding the annual health checks, doing the new, coding, reviewing the notes of patients on all the new patients that then you add the codes on, reviewing the letters from the hospital to make sure that the codes are cross-checked. Just to go back to the prevalence, and I forgot to mention that, that there is a guidance, and which I will send out after this. There is NHS England guidance about which read codes you can use to search to increase the prevalence. So that's a really helpful guide that I would ask you all to just review, and that's something you can add on to that. The last one, and I think within that you can also put cancer screening. And I think cancer screening is certainly one of my favorite ones, which I definitely get my PCN to do, because it covers both the cancer DES and the learning disability. So you could see how many patients, for example, have had screening that are in that sort of cohort, in the learning disability cohort, and how many haven't, and then try and make up a plan, an improvement plan in relation to that. The last question is about your peer review. Now, very helpfully in the guidance, it sets out what should be covered in these peer review sessions, which really is self-explanatory. And as I've mentioned before, that's the evidence that you might have to submit using that template. And I will send you all of the guidances and the templates after with the slides here. Yeah, next slide, please, Chief. Okay. Now, this is what the guidance says that all practices should start as looking at that baseline. So remember, I mentioned the first step is looking at that baseline. So the guidance suggests that you look at the current quality of care by looking at your prevalence. And again, this is a key because we should be 0.5% of our total population, and that's what your percentages are and payments are based on now. So it's looking at the expected population, not what you've got on your list. The second bit about doing TNAs, which is training need analysis, and this could include having a LD awareness for all staff, like a generic LD training. And I was just mentioning to you before we start the webinar that that could include why we do the NEN health checks, what problems patients with LDs have, what the Equity Act is, what are the alerts on the system that the staff need to look at, what sort of appointments are we offering. So it's that baseline really, including some clinical awareness, which could be looking at the Mental Capacity Act and the Equity Act. And we really had an excellent session at our own practice, thanks to Binny. We looked at the mental capacity, and we actually did a simulated clinic with real patients that just really helped the clinicians understand how and where to apply some of the principles. And that's something that I'm sure your local LD teams would be happy to support you with. Do contact them. Again, the contact details will follow after this. This, again, baseline is about looking at that practice approach. So you need to sit with your team and look at how are we booking the AHCs? How are we looking at screening in this cohort? How are we vaccinating? What's our flu rate? How are we looking at health indicators like obesity and smoking? How are we using health promotion? So it's really that on the ground work that you do for any other patient groups. How are we doing for LD, and where are those gaps? You also then look at reasonable adjustments. And again, we've talked about a bit about the reasonable adjustment, but it could be, have you got flags to indicate that there are reasonable adjustments? Or in the summary care records, have you got enough information for the person that you're referring these patients to have information on how to manage their needs? So it's all about that baseline. So it's almost like you're looking at your team and brainstorming exactly what those gaps are. Next slide, please, Jim. So a lot of practices would have actually achieved really well in the prevalences, annual health checks, and actually that isn't a gap from them. So this is the other baseline bits that you can use, including ethnicity recording. If you are doing MDT meetings with the social prescriber and the community learning disabilities team, you can look at any admissions. You can look at referrals. You can look at reasonable adjustment flags, or I've just mentioned to you about having the summary care records with additional information. You can look at how medication reviews, the carers information. So there's lots of other things you can do if you've already achieved and there isn't a gap in what is being recommended within the guidance. Now, I have included 3 main areas or guidances which would help, including NICE, which would help the team identify where those gaps are. NICE specifically, I mean, LEDA and NICE are certainly my area that I think they really are useful in terms of identifying those gaps and what as a practice you need to achieve. So do try and read those. Next slide, please, Jane. Okay, now, after we've collected the data, we've got the baseline, we've known what the gaps are, what do you do now? So the guidance suggests that you meet. This is your first peer sort of support session or review meeting, where you as a PCN would look at the gaps and identify areas which you need to focus on. Now, I have put down LD lead because although this is not in the guidance, I just find if there is somebody who has got that lead responsibility for collating, keeping people together, having that overview on the plan, it just helps bring the structure and things together. But it's not mandated in the guidance, so I would leave it to individual PCN practices to work that out. You'd equally take an approach of doing the SWOT analysis, which is looking at the strength, weaknesses, opportunities, and threat. And again, this is a brainstorming session. You could include the patients, and I forgot to mention the patients here. You could include the CLDT, which is a community learning disability team, and then really come up with a plan, improvement plan. Actually, what are the areas you want to focus on? And again, I have included in here the, sorry, are you guys still able to hear me? Things have just disappeared from my screen. Can you hear me, Che? Can everyone hear me?
Yes, we can, Joyce.
Oh, sorry, I
Yeah.
think everything disappeared from my screen suddenly. So
Don't worry, we can hear you.
Thank you, carry on. So again, I've put some references here, which I found really useful, including the public health sort of profiles, although they're slightly sort of, they refer to 1819, so they probably won't be updated figures that you need, but it gives you that baseline. You've also got some other bits in here. Again, the toolkit is particularly helpful because it would give you ready-made templates that you could use within the analysis that you're doing now. But this is the key, where people sit together as a collective team to come up with the gaps and what areas you need to focus on. And you don't have to focus on everything. You could decide, actually, from now till March, we're going to do X, Y, Z. And then you move on from March to something else. So it is exactly what you want to do, what is achievable. It's down to you and your team, because you could potentially, when I showed you the template, you could potentially answer most of the questions if you use this approach. Thanks, Jay. Next slide, please. Okay. Now, in terms of the planning, the guidance, as I said to you once, so we've just going back to the steps. You've done the baseline, you've had your first view meeting. Now this is the plan. What the guidance is saying is that if you can look at these 4 areas, which is you increase the prevalence. So you've identified people, you've called them proactively to do the annual health check and flu, and have the reasonable adjustments recorded. Now, luckily, if you just call them, the template that you fill out for the annual health check would actually have all this. So you would have done it anyway if you've used the templates that's on the systems now. Now, you remember the annual health checks we've got to do from the age of 14. So the other bit is actually increasing the flu for all ages. So annual health checks for over 14s with flus, and then flu for all ages. Then again, the next bit is about the quality of health checks. This is looking at those action plans, but this is about proactively, or almost you're looking at managing the planned care element of patients with LD. Is their diabetes well controlled if they've got diabetes, or is there a behavior issue? Do we need to refer somewhere? Is there epilepsy controlled? Do we need to get some help, etc.? So that's the action plan, which should be really shared with patients. We are developing an app to try and for patients that can, the carers that can, that would then give them the plan on the app, as well as the next review and next checks for the long-term conditions that they have. The other bit that the guidance asks us to focus on is the flags and the summary care records. I've mentioned about the flags, and this is something I'm going to go back to the NEL-wide sort of IT team. There are some areas that have got those reasonable adjustments flags within their system. Certainly in my practice, I haven't seen those, but I am going to go back, and we will get back to you on how we can equitably get that across the patch for everyone. So the notes show those flags to say that this patient needs reasonable adjustment for whatever they need the reasonable adjustment for. Including in the summary care records, you have to make sure that accessible information standards are met, and the patient's the patients, when you're referring their needs, the person that you're referring to understands their needs, so they can make those necessary adaptations. Next slide, please, Jane. Okay, now I'm just going to talk quickly about creating a plan, because this is actually the key. And for those that have done quality improvement would understand what I mean here. But really just a quick word, because I think this is crucial. So if your outcomes are, just say you want to increase screening uptake, you want to increase the AHC and flu uptake, you need to make those plans or the aims quite smart. And the two main elements here are the percentage and time. So I've used some examples here. So if you've got a patient that show, if you've done your baseline data, and that's showing that only 40% of the patients that haven't attended the annual health check. So you just turn that into a smart aim. And again, I refer you to having the percentage. So you could say, we're going to contact 60% of non-responders over a period of 3 months. So percentage and time to provide appropriate support to facilitate uptake. So that's your smart sort of aim. Next slide, please. I'm just going to use some more examples because I think it's really crucial people get this bit in terms of how you can change from the gaps to the smart objective. Equally, if your baseline shows 50% of the LD have not responded to bowel screening, you could say, I'll contact 100% of those patients in the 1 year and offer support so they can make decisions and have their screening done. Equally, another aim could be that if your baseline shows 40% of the patient have flu jab, your aim is that you will increase from 40 to 60 over 4 months. So having that sort of specific aim would really clarify what you're going to do by when. Next slide, please, Jim. Okay, now this is what, again, for people who've done QI, this would be familiar. So I've talked about the smart aims. The next bit is talking about the some of the all of the data. The measures is the data that you would use, having identified the areas to improve on. So it's understanding what data needs to be collected to know if the aims have been met, and also for the staff to be completely clear on the process's outcome and balance. So, for example, the process could be number of people with learning disabilities, for example, invited for health checks. The outcomes could be the proportion of people with learning disability having personalized health action plan. On the balance, with any QI activity, you have to see, you have to look at the balance of things. And for example, if you are focusing all your attention on achieving the outcomes for learning disability, is it impacting other parts of the system? Is it impacting, for example, your diabetes care? Because the same people are focused all on learning disability. So it's about understanding that balance within the system. And the last bit is the change idea, which is the key element of the PDSA cycle. And that essentially means what are the different ways of doing things that you will test. So for example, it could be just using the example of flu jabs, is we're going to make a phone call. So you'd run a little cycle to see what impact that phone call is made in terms of increasing your numbers, if that's what your outcome is. You could then run another cycle to say, we're going to text patients about the flu jabs and see how that's improved. The third cycle or third change idea could be, actually, we're going to ring the carers and see if that's going to improve your or achieve your outcomes. You then look at that ideas as a team and decide, actually, this is a fantastic idea. We're going to embed this idea, or this is rubbish. We're going to discard this idea, it's of no use, or actually saying, no, we need to go and do a bit more because that change idea needed to slightly be modified, and we can go and run another PDS cycle after we modified and see the improvement. So you get an idea of where it's similar to audit, but slightly different. It's about having that smart aim. It's about the team clearly understanding who is doing what are those changes you can run, when and how you're going to measure it, and then to collectively come as a team and look at that data and adopt the changes or not. Next slide, please, Jim. I know this can appear slightly daunting, but actually the reference that I've given you for the RCGP has got some really good templates that would be easy to use. Now, within the guidance, they don't really sort of specify using a particular technique. What they say is that you should consider whichever tool and technique is most suitable for the improvement plan, which could include the PDSA cycle and the run chart. So this is really using almost like I don't know if people, some people might have had QR training. It's plotting the data on charts and then looking at those charts to see where things have improved or not. Really useful way. It could be a case finding exercise. So you know, the series of code and searches, which I've mentioned before that NHS England has, and see if you then found the missing cases. You could use a process mapping, and that is how the health check calls and reminders and recalls are carried out, and how the process is streamlined as possible. So it could be that you have blood tests at the same time as a health check, etc. So that's the process mapping. Or you could do a structured review. This essentially means that you're sitting with the patients, with the families, and using a certain framework to map out how the practice identifies, records, and implements the reasonable adjustments. So you could use any of these methods to try and achieve the outcome. I mean, my favorite, of course, I absolutely use the run charts all the time. But again, with training, it will be easy for people to do. And as I said, please contact your primary care teams if that's a gap for the area. Next slide, please, Jane. Okay, so just three main things about implementation. Obviously, if you're going to, if you've set something that you've done the cycle, you've agreed and run the plan, and you've agreed the changes to be made, you have to have teamwork. Every member of your team needs to understand those changes. What are the changes? What part would they play in that? I mean, that's the obvious thing. The new process has to be clarified to everyone, including the patients and including the community teams, if it impacts them. I always say involve the PPG local team, CLGT. It's the best way of knowing what those gaps are. It could be all in our heads, but really understanding from the patient groups as well. Next slide, please, Jane. Okay, the second peer support session, which again is very clear within in the guidance as to what should how it should look like. This is celebrating success. It's about sharing the learning and the changes made and the sustainability of the project. This is not about blaming somebody. It's not about you know, about saying that we weren't able to achieve it. It's all about that learning culture, that actually if you have achieved something, even if it's not to target, what are the next steps? So it's about embedding those changes, and there is a recommendation that the clinical director chairs those meeting, but you know, I would leave to you. And obviously with the COVID adaptation, you can do this online. I guess moving forward, that would be the easier things for people to do anyway. Next slide, please, Shane. And I particularly find that helpful because when I did some of the SWOT work, the baseline work, and we were looking at implementing the plan, my reception staff came with a couple of ideas when I thought, oh my God, I didn't even think of that. So it's really, you know, going down that sort of involving everybody. Now, this slide just talks to you about what you need to submit for verification. I've mentioned about the QI template, and I've shown you that before. The slides will be shared, but most of you should have the QI template. And we ask for evidence of attendance. So it could be just that you've attended those minimum 2 peer review sessions, whether they're online or face-to-face, however you want to do it. It would be nice to see some reflection, but it's not what the requirements of the QOF are. It's about just giving the evidence there. But equally, if you fill out the template, there will be reflection there anyway. Next slide, please, Jane. Okay. Now, I'm going to talk to you a bit about the COVID adaptation. So, as I've mentioned before, the annual health checks are to absolutely be done. I say a hybrid model, but you could use the blended approach where you can use some virtual and then face-to-face for the relevant examination, etc. for patients. I've mentioned before that the target was reduced to 67, but please try and aim higher if possible. There is an ask that we target patients who've missed the annual health check last year and record ethnicity again for the reason that the COVID and the risk of ethnic monitoring patients getting more of a risk really, and offering the flu jab. There is some more elements coming out from the COVID vaccine, which we will share. I haven't got the details yet because initially when the cohorts came out, it didn't really specify learning disability. So we have gone back, and hopefully further information about the cohorts that can be vaccinated in the first tranche would come out in over the next week or so at least. Well, we're going to start in a couple of weeks, or next week rather. Yeah, next slide, please, Jean. Okay, I'm here. Really glad to see that I have completed on time. Amazing, actually. So I've given you, I will enclose, as I said, some of the teams, local teams in the attachment that will follow this webinar with the slides. I will put in the quality improvement domains, the document, so you don't have to look at. I absolutely urge people to read the CPORD, the NICE, and the letter report, which I have missed here annoyingly. But please do read that, because it does make really powerful reading. It actually really helps you understand the gaps within your practices. Also, if there are any issues accessing local teams, accessing any data, or any other issues that you have, and even suggestions really, then we've got an email for the NEL LD teams. I'm quite happy to come out to speak to your local teams. Equally, I would encourage the local teams to integrate with its PCNs and practices to try and get that dialogue going. So there is work that's coming through. Also, to let you know, we are going to be doing further webinars in January that we are hoping would focus on some general LD awareness training, the Mental Capacity Act, the Equity Act, and perhaps just revisit the letter report as well. We are also in the process of developing some Q&A kind of booklet to help people, so which they can access with all the questions that are actually coming out from these meetings. So thank you all for listening. I am going to ask Binny if she wants to add anything and answer some of those questions. Binny?
Thanks,
you want to take some of those questions, Binny? I haven't even looked at the questions. I'm sorry.
I have a list. Don't worry about it. So I think there were a lot of questions about blood test. And as I mentioned in the chat, we will be sending out the directory for all local teams, NELT and ELT, that you can contact. All teams do provide desensitization work. So for patients who have needle phobia, who find it quite difficult to have blood tests, desensitization definitely is done in all teams. With regards to phlebotomy, it varies. In Havering, where I work, we do offer phlebotomy service as well, but I'm quite aware, I think in Redbridge, they don't, but we have quite close working relationship with community phlebotomists. So I would strongly recommend that if there is a patient with whom you're struggling with blood tests, do contact the local LD team and they will support the individual as much as possible. And then we need to make a decision based on best interest. Jyoti, there were a couple of questions specifically about the document. So one was about the action plan and standard care plan as to where they could access it.
So the action plan is actually built within the EMIS systems. I've certainly seen it within the system. For people that don't have it, I can share the, I think the managers are probably better at this. They had to download it from somewhere. So can I take that as an action, and I will share the step-by-step guide of how to access it. As I said, I am trying to see if it could be linked with the template. I have sent that message back to the national team, but I don't think it's quite reached the right ears. So I will continue to press that, but I will take that action and share that.
Thank you. And also there was ask about home visits for health checks. I know definitely in Havering, some of our GPs have been visiting care homes and completing the annual health check. I'm not sure about other areas.
So absolutely, Binny. I think the expectation is that it does happen. I think it might be worth as well, Binny, for you to just mention the training that you would be doing for the staff, the news, to recognizing early recognition of deterioration. So do you want to just mention about that? So there is a focus on training the staff to get some of that sort of information. Do you want to just mention that, Binny?
Absolutely. So we will be running identifying deteriorating patient training for care home staff so that they're able to identify. And this comes from LEADER, as Jyoti was mentioning, that we did the rapid reviews for patients who sadly passed away due to COVID from March this year. And one of the findings were patients were presenting quite late to acute hospitals. So we are planning to deliver this training. We're linking in with the training department in NELT because they run the significant 7 training for older adults care homes anyway. So probably we will be adapting that and rolling it out for care homes for people with learning disabilities across the patch.
Just to mention, Winnie, on the blood test, you know how every area, every work stream that's commissioned has to look at the equity impact. So part of the work that we're doing in our patch in BHR is looking, setting up the phlebotomy service. So we are discussing how the vulnerable patients and the learning disabled patient could have access to blood tests in special settings. So that piece of work is something that we are influencing heavily, because that is again equity and a reasonable adjustment. So the local system has to gear towards that. So whilst I understand there's a huge challenge right now and I can't change things overnight, it is something that I'm really proactively working on to change within the systems.
And also, Jyoti, there was a mention about the time taken for the project. So do GPs have the time to do the full QI project?
So as I said, you know, because you already, well, December, you only have a couple of months, you may wish to focus on some, you know, some gaps that you think you'd be able to achieve in the next couple of months, because it is the expectation that you do. And it could be that if you decide to just focus on annual health checks until March, because your practice is one of the ones, certainly like mine, would, you know, end up doing in the last quarter, you do most of the health checks. So I would certainly include that as my quality improvement project to try and increase the uptake of annual health checks. It's about making those small steps. I'm not asking you to do a whole horde of change measures in the next 2 months. It's what is easily done by your practice. What is it as a PCN you feel that you can do to have you know, to change and embed that change moving onwards, and then you can carry on with the cycle. This is a cycle of continual change. So we are absolutely mindful of when the templates are submitted to bear in mind the challenge practices have had, you know, in this time. So, you know, it's people like just me that would be looking at, with the primary care clinical leads, that would be sort of looking at these templates. So I don't think you will need to worry, but equally, I don't want to say just don't do anything, because these are patients that I've highlighted that they've got real needs, and we have to be proactively doing something.
Good. And I think there was quite a few requests for slides from today as well. So I'm sure we will be sending the slides to all attendees, and you were uploading it onto a website as well, weren't you, Jyoti?
Yeah, so all the slides, and thanks to BHR Training Hub, will be on the Training Hub website. However, I've asked Chi to email the slides out with all the attachments that I've mentioned through, so that people have easy access to that. I've got some templates and action plan, which you may wish to use. Equally, you could develop your own. As I said, there are some embedded documents within the RCGP quality improvement, which you may wish to use as well. So there isn't a hard and fast through, but if it's easier for practices just to use the attachments, then that's not a problem, really. The webinar recording will be accessible at any time through the BHR CPIN and Training Hub website. Chi, would you mind putting those details in the chat so people can note and access the webinar at their leisure? Chi, can you do that?
Yes, we'll do that now.
Okay. And Chi, would you mind sending the feedback so they can then get, I think there was a question about attendance certificate, so we can absolutely do that with following on from the feedback, I think. Is that how you work, Chi? Just remind me.
Yeah, so I'm going to send an email with the resources and slides, and they can click on a link to fill out a Google feedback form and get a certificate of attendance.
Vinny, was there anything else from the
Just
question?
one last one, Jyoti. I'm not sure whether it'll be you or Masuma actually answering this. So if they don't have EMIS, how do they access the action plan?
So as I said, I will go back to the team and send a step-by-step guide for all the systems that are across NELS. It's not just EMIS. EMIS just came out because that's the system I use. But what I meant was for all the systems, a step-by-step guide of how you would access the template and the action plan as well. So we can do that. Masuma and I can take that away and get back to you. Anything else, Vinny?
No, and there's one question about the duration of annual health check. It's from Susie Holland. How long should a LD appointment be? Are people having nurse followed by GP? Currently, we have 20-minute nurse followed by 20-minute GP. I think it's quite variable, isn't it, Jyoti? It varies from one patient to the other.
Yeah, and again, this is part of the reasonable adjustment. It's what the patient needs. If you feel that over the phone you've done, you've done the check, there's no concerns, and all the patient needs is, I don't know, blood pressure, weight, height. They could be brought in by, even done by the HCA. So it all depends, I guess, on the patient. Equally, you could have got a complex patient with severe epilepsy that requires, time in the surgery just, to come into the room. So it's all about making those adjustments. So there is no hard and fast rule. The guidance certainly doesn't specify. It just says, giving them adequate time, and that would be determined by yourself, I guess, and sometimes by the patient's needs as well.
Brilliant. And if they've missed the webinar and watched the recording, do they still get a certificate?
So we are actually working on that. So, I mean, she will probably be able to answer that. So what the Training Hub are doing is exactly that, is if they can watch in their own time, then that sends a link. I'm not sure if they've reached that position yet. She, would you clarify?
Not yet, we're still working on it, but I'll put down my email address and just say to me you've watched the recording and I can send you a certificate.
This will be a high trust project that if you have watched it, then that's fine. We'll trust you to get the certificate. That's fine. It's not a problem from my side, really. Anything else, Vinny, before we close?
No, I think that's it, Jyoti. Thank you.
Okay, so a fantastic audience, fantastic questions. Do please attend the webinars that we are going to organize in January, because I think they will be really helpful, particularly to the LD awareness and the MCA, the best interest webinars. I certainly found as a practice when we ran those really extremely helpful. So thank you all. Thank you, Vinny. Thanks to my lovely team, and thanks to all the fellows that are here today.
Thank you.
Thank you.
Thank you.